Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I am discussing one of the important topic, that is management of heart failure. This is Internal Medicine Competency 1.24. So basically I will be describing today the pathophysiology where and the basis by which you give the various drugs. So let us look into what is heart failure. Heart failure is a syndrome where the heart is unable to pump blood for the metabolic demands of the body or can do it only at increased filling pressures. So, heart failure leads on to first and foremost there is decrease in the cardiac output. So, cardiac output is reduced. So, immediately the compensatory mechanism comes. The compensatory mechanism for heart failure initially is the sympathetic nervous system. So the sympathetic nervous system is activated, there is increased sympathetic activity that will lead on to vasoconstriction, and this vasoconstriction improves the cardiac filling in the initial phase. But again remember that the sympathetic nervous system activation will lead on to increased secretion of renin, which will convert angiotensinogen to angiotensin, which is acted upon by angiotensin converting enzyme angiotensin converting enzyme or ACE and angiotensin 2, which is a potent vasoconstrictor again. This will produce increased secretion of aldosterone from the adrenals, and the aldosterone will produce fluid and for sodium and water retention. So this is the RAS activation facilitated by the sympathetic activity. And again, this sodium and water retention will improve the cardiac filling in the initial phase. Aldosterone will also lead on to cardiac remodeling. So even though initially this is beneficial, this can later lead on to complications. So the main pharmacological treatment is controlling these adverse effects of the sympathetic activation and the RAS activation. So what we can do when the heart failure occurs, the sympathetic activity or the heart failure the cardiac contraction can be facilitated by giving inotropic agents. The sympathetic activity can be blocked by beta blockers, which will also block the or inhibit the renin activation. And next is we can give renin inhibitors, which are on the pipeline, and you can block the angiotensin 1 to angiotensin 2, that is the AC inhibitors can be used, and then we can block the action of angiotensin 2 by giving angiotensin receptor blockers ARBs, and the aldosterone action can be blocked by mineralocorticoid receptor antagonists like spironolactone, and finally the fluid retention can be blocked by diuretics. So this is the foundation on which various drugs for cardiac failure is given. Hope this point is clear to you. And now we go into the classification of heart failure. Heart failure is a syndrome of reduced cardiac output leading to various symptoms. Basically, we divide the heart failure into systolic failure and diastolic failure depending upon the ejection fraction. So, heart failure with reduced ejection fraction, when the ejection fraction is less than 40%, ejection fraction less than 40%, you call it as heart failure with reduced. So, this is the systolic failure. When the heart failure with ejection fraction is more than 50%, it is diastolic failure. Between 40 to 50, it is moderately reduced ejection fraction. So we should understand the heart failure is divided based on the ejection fraction. Ejection fraction is a fraction of blood that is ejected during systole. We divide it into heart failure with preserved ejection fraction, that is more than 50%, reduced ejection fraction less than 40%, 40 between 40 and 50, you call it as moderately reduced ejection fraction. So this is the basic classification. That is when suppose the patient had the ejection fraction less than 40% and it has improved to more than 50%, you call it the improved ejection heart failure with improved ejection fraction. So the management of heart failure we are going to discuss is heart failure with reduced ejection fraction, that is less than 40%. We usually go by the goal directed medical treatment. It's called GDMT. This will reduce the mortality and hospitalizations. The four pillars are: one is the ARNI or angiotensin receptor neprilysin inhibitors, AC inhibitor or ARB. So that is the first pillar. Second pillar is beta blocker. Third is mineralocorticoid receptor antagonist, MRAs. And fourth pillar is SGLT2 inhibitors. But again remember, the pillars are owned by support. The basis is diuretics. The patient has got symptoms of congestion, diuretics. On diuretics, you remember these four pillars. So this is how you manage the heart failure. So the foundation, if the congestive symptoms are there, it is diuretics. The ARNI AC inhibitors reduce afterload and ventricular remodeling. The beta blockers will improve the LV function and reduce the mortality. So beta blockers are important in reducing the mortality. The MRAs reduce fibrosis and sodium retention. And SGLT2 inhibitors provide cardiorenal benefits independent of diabetes. That is something that you should remember. So we have discussed the four pillars of management of heart failure in goal-directed management, but the foundation is diuretics when there are congestive symptoms. We'll go to a case. A 68-year-old man presents with exertional dyspnea, orthopnea and bilateral leg swelling. His BP is 130/80 millimeters of mercury, heart rate is 88, JVP is raised. Auscultation reveals crepitations. The brain natriuretic peptide is elevated and echocardiography shows ejection fraction of 30%. So this is an example of heart failure with reduced ejection fraction. Heart failure with reduced ejection fraction. He has got congestive symptoms as evidenced by the pedal edema, elevated JVP and lung showing crepitations. So which class of drug are indicated? Definitely this patient needs diuretics. So the stabilization is with the diuretics and then think about the other pillars for the management. Hope this concept is clear. So the management is guideline directed medical therapy. So now we go to the diuretics. They reduce preload by inhibiting sodium reabsorption and producing diuresis. Mainly in heart failure, you use loop diuretics like furosemide or torsemide, which act on sodium potassium 2 chloride importer in loop of Henle. So that is why they are called loop diuretics. Thiazide diuretics like hydrochlorothiazide and metolazone act on sodium chloride importer in the distal tubule. Aldosterone will be covered separately. As mentioned, the indications are relief of fluid overload, that is pulmonary edema and pedal edema, ascites. So diuretics are the cornerstones when there is fluid retention. This point is clear. So diuretics are indicated when there are congestive symptoms. Let us look at the standard dose. For the furosemide, you give 20 to 80 milligrams daily. This is not for the setting of acute pulmonary edema, but we are discussing is about a chronic heart failure. And hydrochlorothiazide you usually give 12.5 to 25 milligrams per day. So this is the conventional or class the standard treatment for the heart failure when there is fluid retention. Now we go take the next case. 72-year-old man with heart failure presents with worsening dyspnea and leg swelling. She is on furosemide but reports muscle cramps and fatigue. Her serum potassium is 2.8 milligrams. What is the most likely cause and how do you adjust the treatment? So these muscle cramps and fatigue are most likely due to hypokalemia. So furosemide, the one of the important side effect is hypokalemia, and it should be kept in mind that the patient is also on digoxin. This can worsen the digoxin toxicity. So management is to reduce the loop diuretics and add a potassium sparing diuretic like spironolactone. So that should be the management in this patient. So cramps can occur, maybe due to hypokalemia or even hyponatremia. So you have to check the sodium and potassium in this patient. So in this session, we have learned about the heart failure, and when the patient has got features of fluid retention like pedal edema, elevated JVP, lung congestion as evidenced by crepitations, and symptoms like breathlessness, we should start with diuretics. In the next session, we'll be going on to the other guideline directed management and 4 pillars of management of heart failure. Stay tuned.